I am really here to represent the Primary Care Sustainability Group and to give you a little update on what we've been doing over the last 12 months, and also to talk about how we can bring the green agenda to our everyday working life, both as doctors, healthcare workers and patients. And I think that's really important for them to bring it to us as well. So next slide. So as we've already said, that this time last year, if we can move on, Amanda, that'd be great. Thanks, sorry.
All good.
Oh, I've frozen. So this time last year, we said we had, as we said, we had some amazing speakers, and it was really inspiring to see, you know, basically the rock stars of climate and healthcare talking to us. The one thing that sort of came to me more than anything else was that there's great stuff going on nationally in primary care. There was great stuff going on at the trusts, and there were individuals doing things in Cornwall in primary care, but we weren't very well linked up, and we were certainly lagging behind. And I'd like to think that we've now got our fancy dress outfits on and we're starting to become the rock stars. Maybe by the end of this year, we'll be more of a tribute band. So 1 year on, we've got a sustainability action group, and that's essentially a representative from each of the primary care networks. They're not all doctors, which is fantastic. We've got managers and admin, nurses, pharmacists involved. We've been writing a monthly blog and in the LMC newsletter and the CCG newsletter. We've written our own e-bulletin that went out this last week to coincide with COP26. Members of the group have been working on a green energy tariff for the practices. For those of you who don't know, there's nearly 60 individual businesses which make up primary care, and that makes it very difficult to have a collective voice, but we're trying very hard to make things easier for people. Paramedics are often doing the visiting for us these days, and several practices have got electric cars for that, or e-bikes for the doctors to use, and we're working on a lease agreement that everybody can access.
Kath, can I just ask you quickly, because I've just realised that I can't admit people whilst somebody's talking.
Okay, shall I see if I can share?
Yes, you can do it. Annette, could I possibly ask you to see if you can admit people when they come in, because otherwise I'm going to leave people out or abandon Kath, one or the other.
Yeah, okay. I don't mind admitting people, but I can see your screen now, but I couldn't see your slides for some reason.
Yeah, I think that I'm just going to. Do you want me to try again, Kath?
Shall I see if I can do it?
Yeah, you try and do it on your end.
Okay, here we go. Can everybody see that?
We're yes.
Cool.
I can see that. Brilliant.
Okay.
That's much better.
So I'm going to talk a bit more about inhalers in a minute, but we're doing some support around switching inhalers. Kavita is doing a great webinar next month, and it's about giving people the education. Recycling, there's loads of waste. You only have to do a flu clinic to realise how much plastic and cardboard is generated. So it's about enabling people to recycle things in the correct waste bins, and to try and cut down on the single-use plastic that's involved in some of the supply chains, and also working with RCHT on cutting down the stages involved in requesting bloods and urine samples, so that we're not got loads of excess plastic involved there. Ryan's on this meeting. He's done some great travel audits, both of staff and patients, looking at the carbon footprint involved in that as a way of pushing staff to travel to work in a more sustainable way, and also looking at the benefits of virtual consultations when it's clinically appropriate. We've got a funding application in with NHS England, hoping to get a project manager to work on the admin side of this. We've made links nationally with the wonderful people at Greener Practice. I mean, if you've never come across these guys before, I would definitely check out Dr. Tamsin Ellis, Dr. Artie Bansal, Matt Sawyer. They are incredible. How they do this on top of their day job, it's pretty impressive. We've been I guess COVID brought in one thing, and that was a ton of plastic, single-use plastic aprons, gloves, masks. And so we're looking, as we move forward, to work with Revolution Zero and NHS England to get more sustainable PPE and really supporting that. And if nothing else, wearing your climate stripes mask is a good way of getting the conversation started. And we are looking to educate everybody, GPs, nurses, admin, patients, anybody who'll listen to us. You know, we will be on your case and educating the future as well. So making sure that the medical students are aware and put this front and center of whatever they do. So one thing I find more than anything else is that people say to me, well, it's all very well the climate, but what's that got to do with health? Lots of people see it as an environmental issue and don't see it as a health issue. But I think one thing we mustn't forget, as Katharine Hayhoe, the climate scientist, says, we have not a carbon footprint. We also
I think you might have frozen.
to have a climate as a profession. That was very, very apparent during COVID. And the NHS is responsible for 5% of the UK carbon emissions. So we have to get our own house in order, as well as be the means to be part of the solution. If health globally was a country, it would be the 5th largest polluter. So the climate crisis is absolutely a health crisis. And a lot of the time people say to me, oh, I'm too busy, what's the relevance? People just want a pill, I haven't got time for this, COVID's put paid to your green agenda. But if we don't deal with the planetary health, the human health will suffer as well. We have to act on the disconnect that's currently out there between what we know and what we do. The GMC talks about our duty of care to patients and to first do no harm. And there's an open letter going to the GMC at the moment asking them to put human and planetary health front and centre and to consider it in everything we do, consider the impact of NHS actions on the planetary health. And I think GPs play a critical role in responding to this, as we have countless opportunities every day to have those conversations. We just need to reframe it. Quite often people think, well, the climate crisis is happening in the global south, it's not affecting us here. But it is, it's already affecting us. You only need to speak to the coastal communities who've been affected by flooding in Cornwall to see what impact that has. Sorry, this is quite a busy slide, but if you just take the top level, it talks about increased rainfall from climate change, increased sea level rise, and all the mental and physical effects that will have and the pressure that will have on our health sector. And I don't need to point out that several surgeries will be below the flood level of 2015 if you look at the predictions. So places like Perranporth may well find themselves swimming. So I want to take you on a day in the life of a greener GP, and this is about good clinical care being good for the patient and good for the planet. And if we can look at the way the patient pathway goes through their experiences in healthcare, and we can reduce not only the waste, patient time, our time, finances, and we need to empower and support our colleagues and patients to be part of the climate conversation and use it as a reason for our actions and advice. So our first patient of the day is a patient with asthma or COPD, so somebody with lung disease. And this gives you a huge amount of opportunities to talk about climate in a very subtle way. The NICE guidance has been updated to include the relative carbon footprint of inhalers. And I often find that patients are horrified that one of the usual meter dose inhalers, which is the one in the picture for those who are not familiar with it, is the equivalent of a 180-mile car journey, whereas the same drug in a different device is the equivalent of 4 miles. There are 26 million prescriptions in England in 2016-17 of these MDI inhalers, which is the equivalent of 1 million tonnes of carbon. If you switch 10 patients from an MDI to a dry powder inhaler, that's the equivalent of the reduction of one person's annual carbon footprint in a year. So It doesn't take much. So switching is something that we can talk about, and most patients can do this. The other thing is to look at their technique and how well controlled their asthma is. So it's about good clinical care. If we control their asthma properly, they don't need to be using their inhalers as much. The other thing to think about is the disposal of these inhalers. If they get chucked in the bin, they end up in landfill and continue to be a pollution. They need to be incinerated, and we need to put pressure on the manufacturers to recycle the gases in them and have recyclable plastic devices as well. A lot of people think about air pollution affecting London. It's not just a city-wide problem. It is a problem that's affecting the whole world. And you only have to look at the soot and damage that's going on in the Arctic Circle to know that this affects us all. It's the air that we breathe. And so it's an opportunity to talk to patients about maybe making less car journeys, thinking about what they do outside the school drop-off. Do they turn their engine off? Can we cut pollution in lots of different ways? And as a group, we've approached Cornwall Council and the Public Health to try and help us introduce non-idling zones to all the school drop-off areas. And then other things you can do for patients' health is also things like singing and walking, which is good for their health and good for the environment and will improve their lung disease. So our next patient of the morning has come in, and this, I've written heavy periods, but this could be somebody who wants contraception, or it could even be your patient who has that slightly difficult issue to discuss of incontinence and a bit of leakage when they jump on the trampoline, and they're using disposable sanitary towels or tampons. So if you switch from disposable to reusable period pants, for instance, that's the equivalent carbon reduction of 65,000 flights to New York and back from London every year. Each day, 2.5 million tampons and 1.4 million pads are flushed down the loo. We need to remember that the ocean starts in our houses, it starts in our sinks and our toilets, and these things don't need to end up on our beaches. They cause harm to our waterways, and it's the 5th most common beach litter. The other thing you might want to consider is the contraceptive pill. The estrogens in our waterways are affecting the fish populations, and there are other alternatives to using the pill that are pretty good at stopping you getting pregnant or managing your periods. And we need to have the confidence to have these conversations with patients, because it may help them in their choices. It's something that people would consider, and it's shown to be something that people are really considering when they make these choices. Next up is polypharmacy or a medication review. So pharmaceuticals is the largest share in primary care of our carbon footprint, and it's responsible for 25% of the NHS carbon emissions. Medication, again, is an issue regarding disposal of the medication. Often it's flushed down the loo, again, polluting our waterways. The packaging is chucked in the bin and ends up in landfill when it could be recycled. There's some great schemes available to get your blister packs back and being recycled rather than just thrown away. And there's plenty of tools to help us with reviewing patients in terms of their medication. I mean, first of all, nearly half of medication taken long term is not taken properly. Often they're on medication to counteract the side effects of another medicine. And sometimes they've even stopped that initial one, but they're still on the ones to help with the side effects. Taking medication is a risky business for patients, and 6.5% of hospital admissions are due to adverse effects. So we need to make sure patients are educated, they're taking the medication properly, that it's disposed of properly, and there's no waste involved in this. Because if nothing else, it'll save us money. So it's about reducing unnecessary medication, recycling the waste, and re-educating the patients. Next up, somebody with sore joints and wants some painkillers. NICE has been really clear on this. The drugs don't work and actually cause harm and side effects. So let's get people moving. There's no two ways about it. Walking makes you feel good, and we shouldn't underestimate how simple this benefit is. And as well as the benefit to your joints, it has multiple other benefits. Take a walk in nature and you start to appreciate what's around you, and we start to value the biodiversity of the beautiful place that we live in. There's a really interesting study that shows that actually people from lower socioeconomic backgrounds benefit more from being in the blue and green zones, particularly in the coastal areas. And so we need to encourage our patients. I'm always shocked by how many people in Newquay haven't been to the beach, how many kids get through their summer holidays and they've never actually stepped into the sand. And this leads us on to patients with depression and anxiety. There's definitely a role for medication here, and I'm not advocating going away from taking antidepressants when people need them, but we also need to consider the benefits of a social prescription. There's loads of things that come under a social prescription. It's what works for each individual patient. That may be time in a blue zone with cold water swimming. It may be spending times outdoors in nature, whether walking, gardening, but all these things will help us to connect with other people, and we know this is good for our mental health. Being active is good for our mental health, and taking notice of what's around us can also really help the way we feel. So at lunchtime, you hop on your electric bike and you go out on your visit. And I think this is a great opportunity to really ask the patient what's important to them. We're very good at telling patients what they should do, and sometimes we actually need to listen, because sometimes they don't want to take that medication, even if we know it's going to benefit them. We need to look at whether they have become socially isolated during the pandemic and whether a referral to our social prescribing teams would be helpful. We need to enable them to remain active in their own homes and to reduce their risk of falls, because at the end of the day, keeping patients at home or just under the care of primary care reduces their carbon footprint. The minute they step into secondary care, their carbon footprint goes up exponentially. So this is not only about good care for the patient, it's about looking after the NHS and reducing the impact on the services around us. Finally, if you want to make a big win for patient health and for your carbon footprint, you have to look at your diabetic patients. And I guess this is also something that applies to those chronic disease patients, cardiovascular, patients with high blood pressure, heart disease, fatty liver. The way we manage diabetes is really been throwing medication at patients, and we know this doesn't work because otherwise we wouldn't have the biggest number of patients having amputations in Cornwall. Being a diabetic and all the consequences of it are devastating for patients, but we can reverse diabetes, and in Newquay we've been doing a pilot looking at giving lifestyle advice, encouraging patients to eat a plant-based diet, doing some exercise, particularly strength training and walking, and we have reversed diabetes. For those of you that like the numbers, we've had patients with an HbA1c over 100, which is really poor control, and it's now 40, and that is basically reversing their diabetes. They will end up not on medication, they won't end up with all the complications. This is a massive win for their health, and it's also a big win for the planet, because diabetic medication and diabetic treatment have a big carbon footprint. I think it's also important to talk to patients about a plant-based diet. We know this is better for their health, but low quality diets increase their risk of obesity, heart disease, stroke and diabetes. And by switching to a plant-based diet, we can think about potentially preventing 1 in 5 deaths globally. I saw a statistic the other day that said an unhealthy diet is a greater risk to your health than unsafe sex, alcohol, drugs and smoking combined. And we have to have a food system that acts within the planetary boundaries. And by talking to patients about plant-based diets, we can address both their health, climate and ecosystem issues. There are 842,000 excess deaths in the UK from excess red meat consumption. And if we have a plant-based diet, we can reduce that statistics and we can reduce their risk of cancers. If nothing else, more than 1 million people go hungry worldwide, despite us producing enough food on the planet for 2 planets. So when my colleagues say to me, what's it got to do with health? I ask them what they would advise a patient to do in terms of their health. Essentially, they would tell me that they need to be more active, they need to look after themselves better, they need to eat a plant-based diet and spend time in nature. And to me, that looks like a flipping good planetary prescription as well. As GPs, we need to think about reducing our over-investigation and our over-prescribing. We need to think about non-drug options and advise patients about medicine recycling and reducing and returning unused medication. So essentially, what doesn't it have to do with health? Sustainable healthcare is good patient-centred care, and it's better for the patients and it's better for the planet. And we need to reframe the conversation. And at the end of the day, we don't all need to be Greta Thunbergs. In fact, we probably can't. We all need to act, and it's better to have imperfect action than perfect inaction. And I'd like to think we can all be imperfect enthusiasts and start the conversation. Thank you. Right, I'll see if I can get out of there.
That was brilliant. Thank you, Kath. Absolutely fantastic. Some stonking stats in there. It'd be really good to share your presentation and your notes, actually, and then I can load them all up with the recording. But really, really clear, obvious link between human health and planetary health. There were all sorts of questions that I've got. Has anybody else got something that and some really interesting comments coming in? Anything that anybody would like to ask Kath with that wallop of common sense in relation to what you're doing? Hi, Will, good to see you. I'm interested in your take, Sarah, in terms of access to decent food with what you're doing with your community larders.
Yeah, no, I brilliant, Kath. I'm frantically writing notes, and also there's a lot of stuff that you were saying that I think we can put in place and help support within a community setting as well. So the kind of messaging and the support that is coming from different places. And how can community centres work closer with GPs practices to help people within a community, recycle their blister packs, make their own SAMPRO, that kind of stuff, the sort of stuff that you wouldn't be able to do in practice, but actually there's community centres everywhere that we could do those workshops and get that messages reinforced. Food waste is just insane. 84,000 tonnes of food wasted in Cornwall alone every year. It's bonkers.
It's horrible, isn't it?
Yeah. And yeah, there's stuff we're doing every week. We're diverting between 2 and 3 tonnes of surplus food every week at the moment out through community larders in mid Cornwall and further afield. And that's largely available to everyone, but it's mainly being taken by people who are really struggling to make ends meet. So it's tackling a food poverty issue as well. I said the upside of that is that we're able to engage people in other conversations around mental health, well-being, housing, utilities, and their health and well-being. Their health and well-being. So it goes the other way as well. It's not just about food; it's about that wider thing. But food is a really good way of engaging with people and building that trust, enabling people to come forward and ask for wider help.
And I think that's what it's about, Sarah, isn't it? It's, there's so many opportunities to have these conversations and, bring the climate into it. And people, my experience of talking to patients about it is actually they really, really want to consider this. They're probably ahead of the game compared to us in healthcare sometimes. We're always a bit reluctant for some reason to talk about it, or we think it's a separate issue. But we're going to be the ones dealing with the fallout of the climate if we don't get this right, because it's going to have such an impact on people's physical and mental health. I think, there's so many. I think Kavita's comment about social prescribing, I cannot sing the praises of social prescribers enough. Let's if rather than recruiting a load of more GPs, let's recruit more social prescribers, because the work that they've, certainly in my experience of them in Newquay with the Diabetic Project and links with the Newquay Orchard and everything, has been amazing. And they've turned around patients' health that we've been battling's the wrong word, but that we've been trying to engage with for years. And sometimes just that different approach and looking at the barriers. We have 10-minute consultations and you can't explore all those, but actually sitting down and finding out why people are not accessing and why health's not their priority can make such a difference to them, can't it?
Yeah, I think all those, they're really, really key points. This is common garden systems thinking actually is just seeing the dots, isn't it, and understanding that food is one of the things that's at the centre of planetary health and human health. And of course we see health inequality and food inequality. Will, you've very, very patiently had your hand up. I'm quite unused to the polite you. Go ahead.
Yeah, great. I arrived a bit late, but sorry, it's really good to hear people talk about liver disease and diabetes and obesity, and about
Say who you are, Will. Say what you spend your days doing.
Well, I'm a sort of liver specialist mainly at Trelisk, but I've got an interest in climate and health as well. So metabolic syndrome, so diabetes and obesity and dyslipidemia and high blood pressure, that thing. We've been trying really hard to find a metabolic syndrome society group of people that we can engage with to try and get this point across, because they are so, certainly at a secondary care and tertiary care level, they are so tablet focused. Liver disease, fatty liver, people love talking about mice and doing experiments on mice. When I talk about a planetary diet and exercise, they look at me as if I've got some sort of disease. Seriously, it's weird. How can we get this message out there? I mean, I think part of it maybe is I'm in a bit of an ivory tower speciality, where the more toys and the more tech you've got, the better. But how can we get that message out there? Who are the people that got an interest, either a community interest or an academic interest in metabolic syndrome that want to talk about this? Because I cannot find them.
When you say metabolic syndrome, Will, is that just how we eat stuff?
No, metabolic syndrome is the group of disorders which are obesity, diabetes, high blood pressure, and abnormal blood lipids. And you can sort of add on gout, and you can sort of add on sleep apnea. But it's that thing of being overweight with diabetes and high blood pressure mainly. You can just have one of those or two of them. They can be mild or severe. But that's what metabolic syndrome is, broadly speaking. But our approach is all wrong. But I have no idea who to engage with that. What can we do?
Go ahead. Well, I think So there are two population management health projects going on in Cornwall with the PCNs, both in our Watergate PCN and down east. And they are looking at diabetes and metabolic syndrome. And we've got patient experts. We've been involved in the pilot with public health, with looking at the dietary and lifestyle approach to diabetes. And you're quite right, we've seen the improvement in not just their HbA1cs, their diabetic markers, we're seeing improvement in their liver function, and we're seeing improvement in their blood pressure, and they feel better for it. So we have got patient experts. So maybe you and I need to have a conversation, Will, about how we can move this forward, because we've done some great work with our social prescribers, but we can definitely get that, get the voices on the ground to you.
Can I also put in a request for practitioners, community practitioners like Sarah, and people who are running a whole range of community sector organisations to be involved in those conversations, because they could be the messenger that is working with communities while the clinicians are lobbing common sense at the other clinicians. I think we need to
They are, Amanda. We've got them, we're now at the one great thing about Teams in some ways is that actually you start getting people linked up, don't you, that maybe wouldn't necessarily get in a room together. And we've got, community people involved, the voluntary services and the voluntary sector, and those people often have more contact with our patients than we do. So it's about educating everybody so that they can all have those conversations as well. So, and they have the confidence to have those conversations. You don't have to be a doctor to have a conversation with somebody about their diet and their lifestyle. Absolutely.
I'm thinking for you, Sarah, there's something about who, certainly the community maker in your neck of the woods is Bill Davis. I'm just wondering, I don't know the surgeries up that way very well, but I think there's definitely something about a very localized campaign on the importance of food, and then with that, the importance of making sure that people have got access to food, because we can't prescribe a decent diet to people who simply cannot afford it or it's not in reach. So it's understanding all of those complex issues. That's brilliant. I think so. Rupert, you've had your hand up as well. Did you want to pitch in there?
Yeah, it's just a very quick suggestion around the sort of terminology of of how we frame food. And in my later years of general practice, I wanted to say to patients that they've got food poisoning, but never dared. But it's around sort of framing that food can be toxic in excess and in the wrong type. That's all.
Absolutely right. Yeah, I think like it's like anything, not enough water and you die, and too much water and you die. I remember thinking of that when I was 8 and thinking, what a peculiar truth of life, that it's something in the middle. Ian's just made the point, of course, about how do we take these conversations into the medical schools. We've got the Knowledge Spa here, we've got the ECHH, we've got lots of teaching. How do we find a way of making sure that students don't come out of the teaching process, the clinical teaching process, with the presumption that it's going to be a polypharmaceutical response? How do we do something about that? Ryan, have you got something to say there?
Yeah, just on that topic, there is stuff in the grapevine with that. Medical students themselves want to do something. There was a recently group of medical students got together across America and across the UK. And there is now a report that you can access online about how well medical students are being educated per medical school on sustainability issues. There's also a planetary health agenda being knocked around, from my understanding, up in the GP training boards up in London, and that is looking to be approved towards getting that onto the health agenda. There's also a few folks in the Southwest who want to try and push it a bit more locally and see what's being done. And so we're working on it, but it's certainly got a long way to go.
Okay, can you sort of keep us posted in our sector, and people who are working with social prescribers? Can you keep us in the loop, Ryan, in case there's any persuasion that we can get involved in?
Yeah, I can do. I think that there's we're just surveying the Southwest at the minute to see what actually is happening, and then with that we'll hopefully reapproach Health Education England, probably locally first of all, and say, actually, look, you're not doing anything, and you need to, and the students want it, and the educators want it. So that'll be the first hurdle to get through.
Yeah, brilliant. That sounds fantastic. Absolutely. Also, Jim, Ryan, can I just ask, are you in a shed? I'm just worried about your head.
I really like being outside.
Okay.
Yes, I am. I'm out. It was raining, so I've just come into the little tree house that my kids have.
Okay. Don't need to get across yourself whilst offering.
I'm good, comfy. Thanks.
Good. Jim's saying that I'm glad to say that I think general practice has got over itself and now fully appreciates. I think it's probably en route to appreciating, I would say, Jim, but definitely en route. Our SPLW's social prescription link workers are far the best and most effective intervention in getting lifestyle change. And I think I've heard you say before that it's that sort of dawning moment when GPs realise, I'm not the best person here. I am the wrong person to be talking to this person or to be offering advice. I think is really interesting. And Bill, I think Kath's going to jump out and jump again. Something about a conversation with your colleagues, Jim's saying, so you might want to connect.
I think it's that as I say, it's that appreciation that sometimes you, as a clinician, when you start to have that conversation, you can just watch the drawbridge go up internally, and you know that the next 10 minutes of your beautiful explanation are completely wasted. It's made you feel better because you've had it, but actually in terms of making the difference, it hasn't. So, and I think we're all probably very biased on here today, but I think we know the benefits that our social prescribers bring for that. And I certainly say, Bill, I don't know what your experience of having some of those kind of frank discussions sometimes with patients, and appreciating that actually it's a far better intervention for someone else to do that.
Yeah, absolutely right. Absolutely right. And that's quite a big deal for GPs, especially that, it's just a big cultural shift, isn't it? I'm going to go to Melissa and then Kavita, and then I'm going to hand over to Saskia to hear about palliative care and Dorset. Brilliant. Melissa.
Hi there. Can you hear me okay? Because my internet's playing around quite badly. Yeah, I just, speaking as a physiotherapist, I think therapists often in a slightly more or a less time pressured situation. So I get real opportunities working as a physiotherapist to talk to people about their lifestyle choices and unpack some of that. So I think getting therapists and alongside social prescribers, really getting this message out there is super helpful. I have some, I think hopefully, Jim, the drawbridge doesn't go up quite so quickly because people maybe feel they've got a bit more time, and when they're with you, they've got 10 minutes, they want you to be on receive, not transmit. So it's a little bit different for me. So I think, yeah, getting therapists involved has got to be a useful thing to do.
You tend to have hold of one of their limbs at one point there, Melissa. We don't.
It's like extra leverage.
Yeah, sort of in an arm lock.
That's right. Well, that's a really important point, isn't it? Is making sure the same message is being carried by lots of different messengers, actually, especially ones that have got a bit of interaction. Absolutely. Kavita, over to you, and then I'm going to hand over to Saskia.
Sorry, it was just really along the same line as just been said, really, that in adolescent health, generally, there's lots of evidence to say, adolescents won't listen to someone in a position of authority, so a teacher or healthcare provider, when they're trying to deliver sort of that kind of change therapy. So it's no different as we get older. So we just need to choose the right person who's going to be able to pitch it right for that behavioural change, I suppose.